Уважаемые коллеги, мы рады вас присутствовать на первой в нашем новом сезоне спота лекции от Европейской школы онкологии, от ESMO. Для тех, кто вновь к нам подключился, не слушал нас раньше, эти лекции проходят раз в месяц, все они проходят на английском языке. В этот раз тематика лекции посвящена лечению пациентов с метастатическим раком желудка, и основной докладчик или лектор, который будет делать презентацию сейчас, это Sara Dosso, руководитель отделения медицинской онкологии в университете онкологии Южной Швейцарии. И лекция проходит в формате, что не просто доктор читает лекцию, но периодически он вступает в дискуссию со своим, скажем так, оппонентом, другим экспертом из этой же области. Они обсуждают какие-то аспекты, вопросы, потому что, возможно, есть много спорных, дискутабельных вопросов, по которым еще недостаточно данных, и эксперты владеют разной информацией, и это тоже несколько делает этот формат более интерактивным. Соответственно, сегодня в качестве дискутанта доктора Сары Dosso выступит доктор Андрés Cervantes, вновь избранный президент Европейского общества медицинской онкологии, ESMO, хорошо всем известного. И, кстати, тоже еще отмечу, что поскольку мы сотрудничаем с Европейской школой онкологии уже, наверное, на протяжении года, не так давно, в августе, представитель этой организации, доктор Дирк Арнольд, профессор Дирк Арнольд, который является экспертом лечения опухолей желудочно-кишечного тракта. Он является одним из авторов рекомендаций ESMO по лечению данного вида опухолей. Приезжал в Россию, посещал наш национальный центр, посещал онкологический диспансер в Крыму, и также читал серию лекций, посвященную лечению опухолей, в том числе и как раз метастатического рака желудка, представлял все последние данные, последних исследований. Думаю, о них сегодня также будет говорить доктор Dosso. Поэтому тема интересная, тема актуальная. Давайте, я предлагаю всем подключиться. И коллеги, у кого будут вопросы, вы можете их задавать, поскольку трансляция идет параллельно также в Фейсбуке и на нашем канале на Ютубе. Вы можете их оставлять там, на русском языке, не проблема. Мы их увидим, мы их переведем и обязательно тут же запустим в трансляцию непосредственно на сайте Европейской школы онкологии, чтобы и доктор Dosso, и доктор Cervantes их увидели и на них ответили по окончании лекции.
Second or third line approach has been just recently defined. So during the presentation, we will group of patients. So those who are HER2 positive or HER2 negative. In HER2 negative, we go for chemotherapy strategy with platinum plus fluoropyrimidine. And on the other side, in HER2 positive patients, we can also consider the addition of trastuzumab. So what are the milestones in first-line treatment for gastric cancer? The first milestone we have seen in the guidelines that we should consider a chemotherapy approach, as chemotherapy significantly improves survival in comparison to supportive care. And we also have to say that has been demonstrated has combination chemotherapy improved survival compared to single agent 5FU. And then all patients should be tested for HER2 status, and trastuzumab should be added to chemotherapy in case of HER2 positive tumors. And to date, no other target agents have been demonstrated an overall survival benefit in this setting besides trastuzumab. So the first question is doublet or triplet for the first chemotherapy approach. So the standard of care is based on a platinum and fluoropyrimidine doublet, and the benefit from the addition of an anthracycline has been just demonstrated in a meta-analysis, and it is very modest. And it has never been demonstrated in a prospective randomized trial. And also the addition of docetaxel can offer higher response rate, but with a small benefit in overall survival, with considerable toxicity. And here you have the phase 3 clinical trial where DCF regimen, so platin infusional 5-FU plus docetaxel, was compared to platin and infusional 5-FU. And you can see that there is a very slight impact on overall survival, with less than 1 month of benefit. And on the other side, we have really benefit in response rate, with around 40% of overall response rate against 25% with the doublet. But the patient has to pay an high rights for this result, with high incidence of grade 3 and 4 treatment-related adverse event, around 70% in the triplet group, and most of all, it was bone marrow toxicity, as well as diarrhea or lethargy. So, in conclusion, the routine use of taxanes in first line is not recommended, mainly due to the small survival gain, due to the toxicities, but also because taxanes can be given in second line. So we have also to think about a continuum of care strategy in our patient, and so to choose the best first line treatment, but also thinking about what will happen in second line. But there are specific cases in which we can consider the triplet. So DCF regimen, or even better, the analog FLOT, where oxaliplatin is used in place of docetaxel, could be also an option in selected cases. So, for example, young or fit patient, and when we need a very quick response, for example, highly symptomatic patient with a high tumor burden, or if we have a locally advanced tumor and we need the best conversion treatment to go to surgery. So here we remember that you can ask a question and send comments at any time, and we have a special window for this. And coming back to our presentation, the other question is, can cisplatin be replaced by oxaliplatin that we know has a more favorable toxicity profile and is also better manageable in, for example, in our outpatient clinic? The answer is yes, and here there are the explanations. So the first trial was published in 2008 on JCO, and a trend toward an improved median survival was demonstrated for the regimen FLO, so oxaliplatin in combination with infusional 5-FU plus 5-FU. How there is no significant difference in median overall survival, even though the FLO regimen seems to perform better than FLP. Most of all, there are less serious adverse events related to the treatment with oxaliplatin, and therefore oxaliplatin could be demonstrated as a good option in this setting. But in the same year, we also have a confirmation of this result from the REAL-2 trial, which was aimed to demonstrate a non-inferiority of oxaliplatin versus cisplatin and capecitabine versus infusional 5-FU. And the upper limit of the confidence interval for non-inferiority was defined at 1.24. So these drugs were differently combined in 4 different regimens that were compared each other. And so here you have the result. Oral fluoropyrimidine capecitabine compared to infusional 5-FU. We have the upper limit of the confidence interval at 0.99, that is less than 1.23, and so the non-inferiority criterion is fully demonstrated. And at the same time, oxaliplatin versus cisplatin, we have an upper limit of the confidence interval at 1.10, and also in this case, the non-inferiority has been demonstrated. So oral capecitabine can be an alternative to infusional 5-FU, and at the same time, oxaliplatin can be also an alternative, equivalent alternative to cisplatin. And at the beginning of the presentation, when I showed you the ESMO guidelines, we have discussed that there are 2 main groups in first-line settings, so HER2 negative patient and HER2 positive. And in case of HER2 positive patient, we can add trastuzumab to standard chemotherapy. And this is the reason why this is assessed. So the trial was TOGA trial and published on Lancet in 2010. It was a phase 3 trial comparing in HER2 overexpressing gastric and gastroesophageal junction adenocarcinoma, trastuzumab plus chemotherapy versus chemotherapy alone. And here you can see from the disease, the overall survival curves, that there is a clear benefit by adding trastuzumab with an improvement in overall survival of more than 2 months. Here you have an overview of the phase 3 trials exploring the target therapies in first line combined with chemotherapy. And we have to say that just trastuzumab demonstrated a significant role in prolonging survival, and other trial was unsuccessful. Now, in the continuum of care of our patient, now we have chosen the best standard first-line treatment, and we have to move on second line. So in second line, of course, if there is a decrease in ECOG performance status, so the patient is in bad general conditions, we move just on symptom control, choosing best supportive care. But if we have a patient with a good performance status, we can choose a doublet therapy with paclitaxel plus the anti-angiogenic agent ramucirumab, or if the performance status is not so good, we can go for a monotherapy with ramucirumab or irinotecan or taxane. Of course, we have also the chapter concerning the immunotherapy that can be considered in patients with MSI high tumors, but we will discuss later this particular topic. And so the first point is that also in progressing patients, a chemotherapy approach could be considered, and here you have the evidence of several trials comparing in a pretreated patient best supportive care versus any chemotherapy regimen that can be irinotecan or docetaxel. And in all cases, a survival benefit was demonstrated without any difference between irinotecan or docetaxel. And this is the reason why in the guidelines has been described as in case you choose a chemotherapy, a monochemotherapy, is up to the medical oncologist who is treating the patient choose one or the other chemotherapeutic agent. And you can choose mainly according to the different toxicity profile that characterize these two agents. So in case, for example, of irinotecan, we know that there is mainly gastrointestinal toxicity. On the other side, docetaxel is characterized by neuropathy, for example. So we can do our choose according to patient characteristics. So also target therapy has been explored in this setting. And we have to say that ramucirumab was the only target therapy that really demonstrated survival benefit when given as a single drug, and it performs even better when added to paclitaxel in second-line setting, of course. And the trial where this statement was demonstrated was the Rainbow trial, where patients progressing after a first-line regimen were randomized to receive ramucirumab plus paclitaxel, that was the experimental arm, or placebo plus paclitaxel. And you can see how there is statistically significant benefit in overall survival, and this benefit is pretty clear in every subgroup analysis. And so there were no special concern about the toxicity profile, and we know that ramucirumab is an anti-angiogenic agent, so also the toxicity profile is what we can expect. So third line setting, we actually do not have any ESMO algorithm at this moment, because this is something of very new and recently approved. The approval is of last summer. But now we have also a third line strategy for our patients with metastatic gastric cancer, and this is the trifluridine tipiracil drug, so TAS-102. And in TAX trial, that was a large phase 3 trial, was demonstrated a survival benefit when TAS-102 was compared to placebo. We had also, of course, grade 3 and 4 adverse events occurred in 80% of patients, but considering the experimental arm, the adverse events were mainly at the bone marrow toxicities. And on the other side, we have also to say that in around 60% of patients in the placebo group experienced a grade 3 or 4 adverse event. And the reason is that this is a desperate subgroup of patients, because we know that gastric cancer patients in third line are extremely rare, and the adverse events were mainly abdominal pain and, as expected, a general deterioration of physical health. So the last part of my talk will be focused on immunotherapy in esophagogastric adenocarcinoma. So we have that recently immune checkpoint inhibitors have been introduced as treatment for esophagogastric cancer. For example, pembrolizumab has been approved in the US, still not yet in Europe, in selected population, so with gastric cancer with a PD-L1 combined score more than 1, and all solid tumor with an MSI histability. And so in this case, the case, for example, for MSI stability is a tumor agnostic. So we can consider pembrolizumab independently from the primary site of the tumor. But we also know that most of all in gastrointestinal tumor oncologies, but focusing on gastric cancer, there is an urgent need to better define the predictive biomarker for a good patient selection. So here you have an overview of the clinical trial focusing on the use of immunotherapy in gastric cancer. And here you have the phase 1 and 2 clinical trials in heavily pretreated patients, so more than 2 previous lines. And you can see how patients with a tumor with an overexpression of PD-L1 seem to respond better to immunotherapy rather than PD-L1 negative patients. And also the combination of 2 immunotherapeutic agents has been explored in gastric cancer patients. So the trial is the Checkmate 032, is a phase 1-2 trials enrolling 160 patients progressing after more than 1 prior chemotherapy. And you have 3 treatment cohorts: nivolumab at the standard dose, nivolumab 1 milligram per kilogram plus ipilimumab 3 milligram, or nivolumab 3 plus EP1. And the primary endpoint of the trial was the objective response rate. And here you can see how also the immunotherapy combination performs better if we have a PD-L1 overexpression. Of course, is a phase 1-2 trial, so the numbers are very small. And in microsatellite high instability, we have also good response rate with the combination arm. Now let's focus on phase 3 clinical trials. So we have Attraction 2 trial that is focused on gastric and, of course, gastroesophageal junction tumor, adenocarcinoma, in patient heavily pretreated, more than 2 lines, unselected for the PD-L1, and it is a trial including only Asian population. And we have a small but significant advantage in overall survival, around 1 month, in unselected population for PD-L1. And following this trial, nivolumab has been approved in Asian population, so not in Europe, in this particular setting. Then we have also Keynote 061, exploring pembrolizumab in second line in patients with a combined positive score more than 1 versus paclitaxel. That could be considered a standard chemotherapy approach. And here you can see how in the overall population of the trial, there is no significant advantage in overall survival, but if we focus our attention on the patient with a combined positive score of more than 10, we can reach a statistically significant benefit in overall survival. The crucial point is the patient selection. And so we need a more rational categorization of these tumors to explore the real role of immunotherapy. And with this point, the Cancer Genome Atlas Research Network developed a new classification according to 4 molecular subtypes in esophageal adenocarcinoma. And here you can see the classification. The first one concerns the squamous cellular esophageal cancer, so it's something that doesn't matter with our presentation. But here we have the 4 molecular subtypes. So first of all, we have the microsatellite high stability that we know that they have a high mutational burden, and so we also know that they are highly immunogenic. So there we have also EBV positive tumor. They are quite rare, but they are associated to a high PD-L1 and 2 overexpression, and also in this case we can consider them as highly immunogenic. And how to combine these molecular subtypes with a clinical activity of pembrolizumab. And with this aim, a phase 2 trial was conducted and recently published on Nature Medicine. It was investigating 61 unselected patients treated with pembro as a second-line therapy within a phase 2 trial, and a molecular characterization on tissues and ctDNA was performed. And finally, the clinical outcomes were correlated to the molecular and genomic biomarkers for an optimal patient selection. So here you have the waterfall plot according to microsatellite stability and EBV status. You can see how microsatellite stability high is very rare, around 10% of patients, as well as EBV positivity is very rare, around 10%, but when present, they are strong predictive factors of response to immunotherapy. You can see how there is a response rate of 85% in microsatellite high stability and an impressive overall response rate of 100% in EBV positive tumors. And here you have the waterfall plot according the PD-L1 determination. So PD-L1 overexpression at the CPS score was determined in around 40% of patients. And when positive, we can have an overall response rate around 50%, and while PD-L1 is not expressed, the response rate is 0 in these cases. So this is, of course, the cases are very, very small, but probably this is a good proof of concept trial to the further development of immunotherapy in gastric cancer. So, in conclusion, immunotherapy is a tumor-agnostic therapy for MSI high tumors. I have repeated it sometimes, and this is quite clear and demonstrated also in literature. EBV and microsatellite stability are a predictive factor of a response to the treatment, and maybe can be useful, immunotherapy can be useful in pretreated patients if we consider, for example, a PD-L1 combined positive score of more than 10, and this is demonstrated in Keynote 061 with a 2-month gain in a post-hoc analysis. Also, nivolumab could be superior to best supportive care, but only in Asian population. And when used as single agent in unselected population, we have seen that its activity is very modest. We are eager also to see some more results concerning the use of immunotherapy in first-line setting, maybe combined with chemotherapy. We have some data, but probably we need to learn more about this particular concept. And most of all, we need a novel predictive biomarker. So, for example, tumor mutational burden, microbiota, molecular subtypes, and immune signature. And these biomarkers should be validated into clinical trials. So this is my last slide, and finally we came back to the continuum of care of our metastatic gastric cancer. So we are going through an approved first line, and we now know what is the best standard of care for our patient. Now we know that there is also an approved second line, and also just recently a third line. And I have put here in this corner also immunotherapy is not well understood how we can use it in the best manner in the continuum of care strategy, and probably we need some results more for validation of a predictive biomarker to best select patients, but most of all to better understand when is the right moment to use immunotherapy. And thank you very much for your attention.
So thank you very much. Just a second. So thank you very much, Sara. I think it has been a very clear and comprehensive presentation on the options we may have nowadays in gastric cancer. So far, I haven't got any questions from the attendees. So I think in the meanwhile, I would like to summarize what you have presented and to make some comments just to have your point of view on some of them. So first, I think we have in general good news. So we are having more options for more treatment in patients with advanced cancer. When I read carefully the TOGA trial, it was quite impressive that in the, you remember the TOGA trial is a first line, very molecular selected trial. So when the TOGA trial was done, it was a wide participation from patients and investigators from many countries. And from Western countries, considering Europe and US, about 20% of patients got second line treatment. However, this was so in 70% of patients in Asian countries, indicating a different attitude. I think nowadays we have very solid information. Dr. Dosso extensively reviewed that, but second line is very important. So second line is adding something to our strategy. So when we are treating patients in first line, we are at the same time taking care to detect earlier as possible if there is tumor progression, because then we have opportunities. And those opportunities could be mainly taxanes or taxanes associated with ramucirumab. But even nowadays, we have third line. And this is very new in gastric cancer, because we have the data with TAS-102 that Sara presented. This option has been approved recently in the European Union by the European Medical Agency, and I think that's improving the possibilities we have to treat our patients with chemotherapy. So, Sara, would you like to have any comments? And then thereafter, we will come back to the immunotherapy issue. This is, I think, a different one.
Yeah. As you have underlined, is a very, very good news to have a continuum of care strategy for our patients, because I started my medical oncologist career around 20 years ago, and actually for gastric cancer we didn't know after the first line progression if it was useful to give or not a second line strategy. So I think that is very good that we can offer a continuum of care strategy to our patient, and a patient journey, and to prolong, of course, because our efforts are aimed to prolong the survival, and this is quite well explained in my graphics with the improvement not only in progression-free survival but also in overall survival, with a good quality of life, because we know that we can help patient with his disease control. We also go to do something of good also in his quality of life, because we can reduce also the symptoms related to the tumor burden. So I think that is a very, very important strategy in this field.
Another important issue is that we, when we read and pay attention to detailed clinical trials, there is something different from standard of care, because it's not so common to have gastric cancer patients, differently from colorectal cancer, with performance status 0. So I think patients with advanced gastric cancer have a very high tumor burden, and they have really symptomatic, and perhaps many of them, particularly those that are symptomatic, I would say heavily symptomatic, perhaps are not going to benefit from these new strategies that are, in my opinion, mostly benefiting those patients with performance status 0 or 1. Can you comment on this, Sara?
Yes, yeah, absolutely. I fully agree with you. I think that in heavily symptomatic patients, we have to invest the most we can in the first line setting, and for example, considering also triplet combination. And also, I fully agree that patients with a good performance status, with a low tumor burden, can really benefit from this strategy. That is, for example, in second line is aimed to disease control, but we can expect a disease stabilization more than, for example, disease reduction. I have a very, very good clinical experience with, for example, taxanes and ramucirumab in combination in second line. Patients really benefit from this, and there is also a low incidence of side effects, and with improved tumor control. So I think that, for example, this could be a good strategy in this setting.
So there's another point which is a bit challenging, is that, although many patients do present with advanced gastric cancer since the very first moment of diagnosis, some patients will be relapsing after treatment of local regional disease. And we are now moving to float as standard of care in many patients with locally advanced or localized gastric cancer. So how do you think this is going to impact our strategy of reusing taxanes in second
line? Overall, we have to say that float regimen in perioperative setting is not so prolonged, because the treatment strategy is very small period of an highly active chemotherapy, but we treat the patient, for example, for 2 or 3 months, and then go for surgery. And then not every patient can receive adjuvant treatment after a gastrectomy. And so I don't think that really the use of taxanes in perioperative strategy would impact in some way in second-line setting, because then the patient will progress and then go to a second-line treatment. So probably there will be a sufficient interval of time to not to develop a cross-resistant tumor cells.
I think that's sensible, and in fact, patients when we consider the couple of major curves for progression-free survival, most patients in the receiving plot will the ones that relapse will do it very late, and again, reintroducing taxanes is not going to be a problem.
Yeah,
so
I agree.
The other big issue we have, because we have randomized trials, but we have not a clear idea on how to use immunotherapy. Because for me, the impression I have is that immunotherapy is not for all comers. So some patients are getting extraordinary benefit of immunotherapy, but I think we need more and better predictors to establish immunotherapy as standard of care. For me, I think you presented very nice slide on the randomized trials. There is a trend. I mean, when immunotherapy is compared with best supportive care, trials are positive. When it's compared with other type of chemotherapy, this is the case of the Javelin or the Attraction trial, there is no clear difference between one and the other. The data of the first line trial, the only one we have available so far with nivolumab, is not so clear. So, Sara, what would be your attitude on the use of immunotherapy for patients with advanced gastric cancer? Do you go for second line, for third line, after failing chemotherapy? How you would select patients to get the maximum of a potential benefit with immunotherapy?
Actually, I would like to know your expert opinion on this matter, because it's extremely difficult. I will try to answer. What I think that probably only a minority of patients really benefit from immunotherapy of gastric cancer patients, and only few patients and very, very good selecting, with a very, very good selection. And in my clinical practice, of course, I consider MSI instability, of course, and in case I go with second line with immunotherapy, because I think that we have solid data to do this. And but for the many other cases that are the majority, because it's the 90% of cases, in gastric cancer, I go with a standard second line with, if the patient is fit, with ramucirumab plus paclitaxel, that I like it very much. And then in case of DL1 overexpression at the progression, I consider an immunotherapy. But for me, it's very, very difficult to understand if immunotherapy will be an option for our gastric cancer patient, and most of all, where put immunotherapy in the algorithm. And as you can see in my slide, immunotherapy is put on the right corner because I didn't know, and I think that we have no data to consider this. And so in clinical practice, we do not have a strong evidence to translate the results, and that can guide our decision. And I think that we have to consider every single patient and to try to select them according to MSI status, EBV, PD-L1, and then to consider as an alternative, for example, in case of patient who developed neurotoxicity after a first line with oxaliplatin, and then there is a PD-L1 overexpression. Actually, I would consider also an immunotherapy, but we have, of course, also ramucirumab, monotherapy, irinotecan as alternatives. So I think that we have to discuss every single cases and to decide for every single patient, maybe some different that we have done the day before for another case.
I think it's you are right, but I really enjoyed very much that you presented the Korean trials on predictive biomarkers, because I think in our strategy of managing advanced gastric cancer patients, even localized gastric cancer patients, for example, determine microsatellite instability, which is relatively a cheap test. I mean, if you determine by immunohistochemistry the 4 MMR proteins, and those proteins are stable. I mean, if you have stability of microsatellites, I don't think immunotherapy is very much needed. So the other way around, if I found that a patient is presenting microsatellite instability or Epstein-Barr virus positivity by the EBER test, which is essentially fish, then those two are very strong predictors of the effect of immunotherapy. So I would like to know the subset analysis of the first-line trial, because potentially, if I had in front of me a patient, 73-year-old patient with microsatellite instability or Epstein-Barr virus, I would go straight to immunotherapy, knowing that I'm going to get a good prolonged response in most of these patients. But I would never start immunotherapy first line in a patient in which platinum is going to be tolerated, platinum combinations, and then we can go on the strategy of adding paclitaxel, ramucirumab, etc., etc. So I think it's important to know better predictors of response. I understand, and you stress that very well, that microsatellite instability and Epstein-Barr virus is a very small proportion of patients. But if you have there, by testing upfront these biomarkers, the same way we start always testing HER2. So if we start by doing HER2, I would recommend doing HER2, MSI, and Epstein-Barr, because this may help us in shaping the sequencing of our treatments for this disease. The point is that, of course, perhaps some patients with non-microsatellite instability, non-Epstein-Barr, may also respond to chemotherapy. So we need to identify those patients better. There's a very nice paper in Annals of Oncology published by the group of Patrick Tan in Singapore in cooperation with some other Asian investigators, showing that the use of of the hypermethylation of promoters, which is a standard epigenetic way of silencing genes. The use of these promoters may also facilitate the effect of immunotherapy. I think this is nowadays under research, but I think I would stress is not to provide immunotherapy to all comers, but try to get some better predictors to use this type of effective treatment, expensive treatment, potentially toxic treatment, with better profile than chemotherapy. But also, I mean, I think if we have in our hands better predictors, we can manage better when to select immunotherapy for advanced esophagogastric cancer patients.
Thank you, Andrés. Thank you very much for your expert position. And I think that we are perfectly on time and something like us with time. And so we have to close this very interesting session. Thank you very much for your inputs.
Thank you.
Thank you to the attenders.
Thank you, Dr. Dosso, and thank you, Dr. Cervantes. Austria. The following topic: head and neck cancer patients.
Коллеги,
Integration of nutritional management.
да, можно?
in cancer.
Спасибо всем, кто к нам присоединился, всем, кто смотрел трансляцию. По-моему, очень такой доступный был формат, скажем так, донесения информации, в том плане, что такая краткая, но очень емкая выжимка состояние дел с терапевтическими возможностями пациентов с метастатическим раком желудка, особенно последний слайд, ну, его можно будет посмотреть, когда мы выложим в записи эту трансляцию, ну, можно сфотографировать, да, видно, как происходила эволюция всех этих опций и что мы имеем на сегодняшний день очень четко. То есть я просто еще раз обобщу, да, если, может быть, какие-то проблемы с английским из тех, кто нас смотрел, что в настоящее время, да, у пациентов, то есть буквально за последние 15-20 лет изменилась ситуация в лучшую сторону, в том плане, что теперь таким пациентам с распространенным метастатическим раком желудка доступна не только первая линия лечения, но также появились вторая и даже третья линии. Выбор первой линии это зависит от того, хер-позитивный или хер-негативный рак желудка. Соответственно, если это хер-негативный, то назначается химиотерапия цисплатин с фторурацилом или препараты платины с фторурацилом. И если это хер-положительный рак желудка распространенный, тогда показано в рандомизированных исследованиях, и сейчас это стандарт, что химиотерапия обязательно сочетается с назначением трастузумаба. Если говорить о второй линии, то здесь уже опять-таки, если раньше было только то, что называется лучшая поддерживающая терапия, да, best supportive care, или иногда назначали химиотерапию, то сейчас показано, что химиотерапия эффективнее, и она увеличивает выживаемость таких пациентов. Но более того, сейчас химиотерапию сочетают еще и с анти-VEGF, эндотелиальный фактор роста сосудов, препарат рамоцурумаб. В сочетании с химиотерапией, опять-таки, доктор Dosso продемонстрировал исследования, в которых было показано, что сочетание рамоцурумаба с химиотерапией более эффективно и приводит к лучшим результатам у пациентов, обеспечивает лучший контроль над заболеванием, чем просто химиотерапия. Кроме этого, во второй линии появилась такая опция, как назначение иммунотерапии, однако это не для всех пациентов, а только для тех, у кого опухоль MSI high с высокой микростолитной нестабильностью. И Если говорить про пациентов, у которых развивается дальнейшее прогрессирование заболевания на фоне уже этого лечения, на фоне второй линии, то сейчас есть даже вариант назначения третьей линии химиотерапии, не химиотерапии, простите, опять-таки речь идет об иммунотерапии, но тоже только для тех пациентов, у которых опухоли положительные по PDL1. Но, в частности, в дискуссии, если вы обратили внимание, Sara Dosso обсуждала с президентом ESMO тот момент, что, безусловно, третья линия и назначение иммунотерапии, к сожалению, возможно, не у всех далеко пациентов, которые прогрессируют после второй линии, потому что здесь очень много зависит от соматического статуса, от общего состояния пациента, а, конечно, уже на третьей линии многие из этих пациентов просто по критериям, они не удовлетворяют тому, чтобы им назначить дополнительное лечение. Некоторые пациенты просто сами отказываются от получения каких-то еще терапевтических опций, поэтому здесь, конечно, вопрос стоит еще и в этом. А именно максимальный эффект иммунотерапии, безусловно, может оказать только если у пациента ЭКОГ-статус 0,1. Собственно, вот такая краткая выжимка из того, что рассказала доктор Dosso и о чем была дискуссия с действующим президентом ESMO. Я надеюсь, что те, кто не успел посмотреть, или те, кто, может быть, уловили не все моменты, обязательно смотрите запись-трансляцию, которую мы выложим на нашем канале в YouTube. И также сейчас у нас еще нету программы на месяц вперед, но обязательно у нас будет следующая лекция ESSA ровно через месяц, поскольку она у нас один раз в месяц по вторникам, последний вторник каждого месяца. Соответственно, тему мы выложим заранее, сделаем анонс, и следите за нашими обновлениями на Фейсбуке и в Инстаграме. Мы там выложим расписание наших следующих сессий спота, которые мы будем проводить. Большое всем спасибо, всего доброго.